Biliary ultrasound, albeit a more advanced bedside ultrasound modality, will serve to guide you with your abdominal pain workups and also to speed patient disposition. This lecture will discuss various facets of the right upper quadrant ultrasound. The objectives of the lecture will include deciphering the anatomy of the right upper quadrant, which at first glance can be somewhat complicated. We'll also focus on a methodical, comprehensive approach to the right upper quadrant ultrasound. We'll move on to the porta hepatis and discuss various approaches for identifying the common bile duct. Next, we'll look at various types of biliary pathology, and then finally discuss liver pathology with relation to the gallbladder. Anatomy, as usual, is the hardest part. The gallbladder is a tubular structure that's anterior wall is contiguous to the liver. Unfortunately, does have a variable axis and a variable location. The porta hepatis is made up of three components. One is the portal vein, two is the hepatic artery, and finally the common bile duct. For our purposes, the cystic duct and the common bile duct are typically not distinguished. This too has a variable location. When positioning your patients, you're going to want to start supine, and this is completely supine. You can have the patient extend their right arm above their head or flex their trunk to the left. Also, you might try a lateral decubitus position. As usual, having the patient taking a deep breath and hold can improve your imaging. If you're not able to identify the gallbladder in the mid-epigastric and subcostal space, it may be helpful to use the intercostal space, aligning the transducer with the patient's ribs. Even posterior may work and may be necessary depending on the lie of the patient's gallbladder. Now, looking at surface anatomy, the gallbladder, as usual with its variable location, may involve you pointing the probe towards 9 o'clock, towards 12 o'clock, or even towards 3 o'clock. Again, you want to think longitudinal when first identifying the gallbladder. One of the ways I teach the residents is to use a gel bottle. As you can see here, I've labeled the gel bottle with the gallbladder neck as well as the gallbladder fundus. What's in between the two of these is the gallbladder body. This is the typical lie of the patient's gallbladder, which at this point has the neck superiorly, as usual, and the fundus most inferiorly. So you may get lucky and the gallbladder sits in a perfect vertical positioning, but unfortunately, that's not always the case. Sometimes the gallbladder will lie with the neck pointed towards the patient's right shoulder. The other option is for the gallbladder to point with the neck towards the patient's left shoulder. Typically, when I'm imaging gallbladders, I find that the gallbladder is either sitting with the neck towards 12 o'clock or slightly towards the patient's left shoulder. Now, why is this relevant? Well, it's relevant because you want to have the patient's gallbladder neck on the right side of the ultrasound screen as you face it. And so in this case, the sonographer is holding the probe like a pencil. The probe is placed in the mid-epigastrium, starting off with the probe pointer indicator up towards the patient's head. Once the gallbladder is identified, then we find a true longitudinal. In this case, the true longitudinal has the gallbladder neck pointed up towards the patient's left shoulder. Note how the probe is rotated in such a fashion to achieve a nice longitudinal. Now we move from a longitudinal to get a short axis of the gallbladder. We do this by turning the probe counterclockwise 90 degrees. As that gallbladder neck was pointed towards the patient's left shoulder, now we're pointing towards the right shoulder to achieve a short axis. Again, counterclockwise rotation, pointed towards the patient's left shoulder. Again, this is only for gallbladders that would indeed be pointing up towards the patient's left shoulder. Next, we mentioned that sometimes a subcostal view is not possible. In this case, we can obtain an intercostal view, angling along with the angle of the ribs. This may be necessary in some patients. And then finally, having the patient turn onto their left side into a left lateral decubitus can be very helpful as it brings the gallbladder closer to the abdominal wall. If you're having difficulty, certainly have the patient turn. The same sonographic technique holds even in the left lateral decubitus. Before we launch into a discussion of sonotechnique and image acquisition, a quick mention of documentation. We'll reiterate this towards the end of the lecture. For documentation purposes regarding the gallbladder, you'll need to save 4 different views. The first view is the gallbladder and longitudinal, and then a gallbladder in transverse high, mid, and low with calipers that measure the gallbladder wall thickness. This will be in addition to a transverse of the liver as well as a measurement of the common bile duct. Now, I'll always recommend additional videos of both the gallbladder and longitudinal and the gallbladder and transverse that document a thorough comprehensive scan. This is an example of what you might see on a still image of the gallbladder and longitudinal. What you find here is a normal gallbladder wall thickness, clearly delineated wall of the gallbladder, with no echogenic structures within the lumen. It's sometimes seen to have this nice white line that connects it to the portal vein, in this case probably the right portal vein. This line is the main lobar fissure. You can then obtain views of the gallbladder transverse high, mid, and low by turning the probe 90 degrees. And as you can see here, we're measuring the wall that's adjacent to the liver parenchyma. We're measuring perpendicular to the wall, trying to assess for gallbladder wall thickness. We do this at both high, mid, and then finally low. The reason that we do it on this side is that it becomes a little indistinct, a little fuzzy on the side that abuts the bowel. Quick details on the gallbladder. It can be a variable size. Once its length and its diameter exceeds the numbers that are listed here, you have to think about gallbladder hydrops, which would be part of the sonographic considerations of cholecystitis. Additionally, the gallbladder wall thickness can vary, especially after a patient has eaten. Typically it's less than 3 millimeters, but can become thicker in that situation. The normal anatomy can also be what we would term abnormal. You can see folds, you can see septations in about 15%. This is again a normal finding. Contrast those sharp walls to that of cholecystitis, which you'll see later, where there's more wall edema and wall thickness. Now, of course, scanning through the gallbladder requires a very methodical, comprehensive approach. The problem is that stones tend to accumulate around the cystic neck. With that in mind, you have to be very careful in this area. Additionally, we'll bring up this concept of a sonographic Murphy's sign, which contrasts from your typical physical exam. We're looking for pain directly over the gallbladder, but nowhere else. We'll discuss this again. Here's a video of a normal longitudinal gallbladder. As you can see, there's no evidence of any echogenic debris within the gallbladder, no shadowing. What you do see are some parallel lines that extend into the gallbladder lumen. This is an artifact. This is reverberation artifact that's probably deriving from some of the fascial planes of the abdominal wall. So this is not uncommonly seen. Now, turning the probe 90 degrees, we're able to obtain a gallbladder transverse image. So as we're scanning through from the neck to the fundus of the gallbladder, we're looking again for any evidence of echogenic sludge or stones, etc. We've talked about the 1 through 4 views, so the gallbladder long, gallbladder transverse high, mid, and low. Now our 5th view will be the portal triad. This is also described as a Mickey Mouse sign. We're looking at this in transverse. On the image on the right side of the screen, we can see the portal vein. We can see the hepatic artery. Then we can see the common bile duct, which is being measured inside wall to inside wall. This is the Mickey Mouse sign. You can describe this as being the right ear of the Mickey Mouse facing you, or the left ear of the screen. Either way, this is the classic appearance. The CBD itself is usually less than 3 millimeters, always less than 9 millimeters. The best way for you to remember this is that patients get essentially 1 millimeter per decade of life for age divided by 10. That said, after cholecystectomy, the CBD can be increased in size up to 1.3 centimeters. The 6th view is that of the liver, which is one big transverse view, specifically to look for any liver pathology, things like intrahepatic cholestasis, tumors, cirrhosis, etc. And of course, imaging all abnormalities in at least 2 orthogonal planes. Let's look at the liver in a little bit of detail. So the liver is going to be composed of the portal venous system as well as the hepatic veins. So the idea of the hepatic veins is that they lack echogenic walls. They converge on the IVC. So when you're looking at this image on the right side of the screen, your first consideration is, why is it labeled bile ducts? Well, that's incorrect. So that's not the correct labeling terminology. These are hepatic veins which are coalescing on the patient's IVC. This is the antler sign, or sometimes termed the Playboy bunny sign. Now, the hardest part of the right upper quadrant exam, in my opinion, is to find the porta hepatis and to measure the common bile duct. I would advocate 4 different approaches, but focusing specifically on the first approach. So the first one is turning from a longitudinal of the portal vein to a transverse, thus obtaining the Mickey Mouse view. You can also follow the splenic vein to its confluence and either obtain the transverse immediately or turn from a longitudinal to a transverse. You can follow all the portal vessels distally to proximally, where you'll see the main portal vessel in the Mickey Mouse view. Or finally, you can follow the hepatic artery from the celiac trunk. Let's talk about these each in detail. The first approach involves placing the probe in a orientation such that it's pointed up towards 11 o'clock or the right shoulder. Again, this is the indicator. This is because the portal vein runs in the same line. If you do that, then you are able to obtain a longitudinal of the portal vein, which if you turn the probe counterclockwise 90 degrees, usually to about 8 o'clock, you obtain the Mickey Mouse sign. And this is what you end up seeing here. We have a longitudinal and we turn it into a transverse. So let's watch this again. We're going to see a longitudinal of the portal vein into a transverse. And we see the portal vein, hepatic artery, common bile duct. And importantly, the common bile duct runs on the anterior surface of the portal vein as you see it in longitudinal. That's where radiologists typically measure it. Approach number 2 involves using the splenic vein, or the superior mesenteric vein. The idea is that the portal vein is composed of that confluence of the splenic vein, the inferior mesenteric vein, into some part the superior mesenteric vein. This confluence forms the portal vein, and that's what we're looking for. So we're going to follow the splenic vein. We're going to place the probe in the mid-epigastrium in transverse. We're going to watch the splenic vein as it passes over the SMA, or the superior mesenteric artery, and then becomes the portal vein. This is an example right here. We have the aorta, SMA. The splenic vein is starting to cross over. And then we see the splenic vein once again. This is going to form the portal vein. So let's take a look at this. So we're seeing the splenic vein now in longitudinal turning into the portal vein right through here. Let's watch that again. So we see the splenic vein going over the SMA, and now it's going to form the portal vein. We could then turn the probe 90 degrees and find a transverse image of the portal vein and the Mickey Mouse structure. So we could go from longitudinal to transverse. The same idea as the first approach for identifying the CBD. Longitudinal to transverse. And in this, as you recall, we're looking for the common bile duct right there, hepatic artery on that side. Third approach, we can follow the portal vein from above, so going from distal to proximal. So in this case, place the probe in the mid-epigastrium, so it's the transverse plane. Point all the way up towards the patient's head, get a high cut, and then rock the probe inferiorly to follow the merging of the portal vessels. So we're pointing all the way up, and then we're following it all the way down until we see the portal vein right here. And then we can find the Mickey Mouse sign. Pointing all the way up to the head, and then pointing back down, looking for that transverse of the patient's portal vein. Great, so the next approach, number 4. This is to place the probe in the epigastrium in a transverse plane and looking for the celiac trunk, or the seagull sign. As you recall, the celiac trunk sends a branch, which is the splenic artery, and then a branch, which is the hepatic artery. We can follow that all the way over until it forms its component of the porta hepatis. And what you end up seeing here in slow motion is the celiac, and then we watch this vessel right through here forming its component of the porta hepatis. Here's another example of the same finding. take a good look at this, and we'll repeat again. So we can see the celiac right here. We can watch this hepatic artery coming across, and it's going to form that ear, portal vein, and then the common bile duct. Now that's all easy enough to see this on the screen. That said, it's a really difficult technique to get used to. So unfortunately it may not be in a classic location, and if the patient doesn't have a nice sonographic window, i.e. the liver, then you may need to use an intercostal space, and it's going to make it more difficult. But just to convince you, this is what you end up seeing. We see a portal vein, hepatic artery, common bile duct. You can even put color flow on it just to convince yourself further, where you see the portal vein lighting up, the hepatic artery lighting up, and then you have your CBD. Before we launch into a discussion of gallbladder pathology, let's talk about why we even do ultrasounds in the first place. Well, studies have shown that it decreases the patient's length of stay in the emergency department, that there's less expenditure of resources. It really focuses your technique as well in your diagnostic studies, such that perhaps a patient will be spared a CT scan. Additionally, we're pretty good at it. Emergency physicians have a high sensitivity for identifying gallstones by ultrasound, with ranges of 86 to 96%, specificities 78 to 97%, and a positive predictive value in the mid-90s, with a negative predictive value in the high 80s to low 90s. We're also great at identifying cholecystitis. Moreover, it provides information about some other things, including aortic pathology, abscesses in the liver or around the kidneys, and also in the identification of pancreatic pseudocysts. Now, regarding gallbladder disease specifically, men have a lifetime incidence of around 15% for suffering from gallbladder pathology, while women are about 2 times as more likely. Most stones tend to be asymptomatic. However, once a stone is identified, there is a certain baseline rate of patients developing symptoms over the course of each year. This may take the form of simply biliary colic or something more serious like cholecystitis. And this is not a phenomenon that tends to go away. So to simplify, asymptomatic stones are not treated. Symptomatic stones, however, are treated with cholecystectomy. Let's talk about stones briefly. Their typical composition is approximately 80% water. The rest are bile salts. I want you to focus specifically on the cholesterol component of this. Since cholesterol is the most common cause of stones, this is obviously a preventive health measure which should be focused in the outpatient setting. Additionally, you can see stones that are composed of bilirubin as well as calcium, and these are patients that can follow up with their primary doctor for further workups. Your goal is simply to identify the stones in the first place, recognizing that increased cholesterol content in bile will lead to the development of stones. This can occur in the setting of marked obesity, recent weight loss, some cholesterol lowering drugs. Additionally, with decreased bile salts, you see the precipitation of stones, which can occur in the setting of advanced age, certain genetics, estrogen, as well as recent weight loss or dietary restriction. So what ends up happening is the patients develop asymptomatic sludge and or gallstones, which then over the course of several years may suddenly become symptomatic. You see the patient in the emergency department. They may look toxic, they may simply have biliary colic, but then ultimately these patients will go on to perhaps have a few complications which will necessitate emergency surgery. As we discussed, the sensitivity and specificity of ultrasound in the detection of gallstones is reasonably high. The things we're looking for are increased echogenicity of stones. We're looking for shadowing in stones that are typically greater than 3 millimeters. This type of shadowing is termed clean, as opposed to the shadowing that you see from bowel loops that are full of air. Finally, the stones are mobile. They follow gravity, so moving the patients, these will tend to move around in the gallbladder. This would contrast from gallbladder polyps, which would not do the same thing. So identifying stones. It's easy if the stone is huge. You can't miss these. Sometimes they're more of a medium size, which are still easy to see usually. Finally, there are the small stones, which tend to be very hard to see. They have the appearance of gravel, and as they get closer to the gallbladder neck, you become more and more concerned. It's one of those unfortunate phenomena that the smaller they are, the more pathologic they are. So looking at this video, we see a large echogenic stone with posterior shadowing. In this case, the patient had simply biliary colic. This would not be a stone you would miss. Now these are smaller stones, but still easily identifiable. As you look in the lumen of the gallbladder, we see echogenic structures with acoustic shadowing that emanates just posterior to it. This is another example of the same finding. And then watching this video, we can see the patient's kidney, and now we see a number of stones that fill up the patient's gallbladder. We can also look at the same structure in transverse, and we can see the stones with their acoustic shadowing. Unfortunately, it's not always that easy. In this case, you can easily misidentify these echogenic stones as part of the gallbladder wall. We can see some shadowing that derives from those stones. Here's another example of the same finding as the stones tend to accumulate towards the neck of the gallbladder. This is a video of the same finding. This is somewhat difficult. These are somewhat difficult structures to identify, especially if the patient presents with a difficult exam from morbid obesity, etc. So I want to reiterate, small stones are easy to miss, and unfortunately they're just as, or perhaps even more, pathogenic. So you need real-time, slow, methodical sweeps, and then focusing specifically on gallstones in the neck or the cystic duct, which are easily missed. This is a good example of one of those findings where you might simply attribute this to edge artifact, but instead there is a stone in the neck of the gallbladder. Here's another example of a patient who came in with severe right upper quadrant pain. In the first ultrasound, this was missed. On the second ultrasound, there was identification of a small echogenic stone in the neck of the gallbladder. Some sonographers refer to this as the SIN, or stone in neck phenomenon. Some other misses would include gallstones in a contracted gallbladder. This is really difficult because you never see the anechoic lumen of a gallbladder. Instead, all you end up seeing is a bright white line with some dark shadowing just beneath that. This is wall echo shadow, the WES, West sign. The arrow indicates the contracted gallbladder with the stones as well as the acoustic shadowing. So let's watch a video. Unfortunately, the sonographer has the probe turned around 180 degrees, but instead within the parenchyma of the liver we see a bright white line, and below that bright white line we see dark shadowing. This is wall echo shadow. You can also see this in the setting of a porcelain gallbladder. Here's another example with the probe turned around. Again, we see that same bright white line, and then we see that dark shadowing next to it. So we're concerned about a gallbladder that's contracted around a number of stones. So take a look at the still image, and you're asking yourself, well, what could I use to differentiate between the shadowing of stones versus the shadowing of simply air in the bowel? Well, in this case, you can see the dark shadowing from the stone is indicated by the large arrow, and then some dirty shadowing, some gray shadowing from the air within the bowel. Again, this would be wall echo shadow on the left side of the screen versus bowel shadowing on the right side of the screen. Here's another video of the same finding. This is a patient who was having mid-epigastric to right upper quadrant pain. And we performed an ultrasound, couldn't find the gallbladder, thought about performing a CT scan, took another look, and instead what we find is a gallbladder contracted around a number of stones that have produced some pretty significant clean shadowing. This is wall echo shadow that you're able to see here. On ultrasound, sludge looks like the way the word sounds. It appears echodense, it has a lava lamp appearance, and also it tends to be dependent. So moving the patient, it's going to move around within the gallbladder lumen. as it's the precursor to cholelithiasis, it is relevant to note its presence. That said, beware pseudosludge. This tends not to layer out, it extends beyond the walls of the gallbladder and is generally due to sonographic artifacts. This is a good example of sludge. You can see this within the lumen of the gallbladder, and then you can also see little pieces that are floating around just like a lava lamp. In this case, we see the obvious pathology here, which is a large stone with acoustic shadowing, but there's also some non-shadowing debris within the lumen of the gallbladder. That's an example of sludge. In this video, we can scan through the gallbladder and we see the same finding in the fundus of the gallbladder. In this next video, we see a gallbladder that's chock full of the same sludge. Again, it has a non-shadowing appearance, and in this case has distended the gallbladder with its contents. Next, let's talk about the sonographic Murphys. We mentioned this earlier as a sign of cholecystitis. So when we talk about the Murphy sign, we're specifically referring to the physical exam where you place the hand in the patient's right upper quadrant and have them take a deep breath. And if they have pain, then you check the box. It's positive. Well, this is a little bit more complicated. You want to identify the gallbladder right underneath the probe. You press with the probe. If the patient has pain there, that's step one. You then press in other parts of the abdomen. If the patient has pain nowhere else, then that's a positive sonographic Murphy's. If they also have pain in the left lower quadrant or suprapubic space or some other part of the abdomen, then it's a negative sonographic Murphy's. Its sensitivity is not great, but its specificity is quite high for cholecystitis. We also mentioned gallbladder wall thickness before, a normal thickness being less than 3 millimeters. However, in a postprandial state, this can cause increased thickness. When you do see pathologic thickness, in most cases it's actually not due to cholecystitis. It's usually not due to a cause that will require a cholecystectomy. Instead, it's things that are due to volume overload states. Things like CHF, end-stage renal disease. A normal gallbladder wall, however, also cannot be used to rule out cholecystitis. As you can see, its sensitivity is reasonably low. As we discussed, the gallbladder wall should be measured with calipers adjacent to the liver parenchyma. So it's the wall that's adjacent to the liver parenchyma at both the high, mid, and low transverse planes. This is a good example of that same finding. This is a transverse low with a wall that's adjacent to the liver. And as we can see, it's clearly delineated. We can measure that. In this case, it's 1.6 millimeters. Contrast this from this transverse high image where the gallbladder wall thickness is 8.6 millimeters. This is in a CHF patient. This is the same patient as we're scanning from the patient's fundus all the way down to the neck of the gallbladder. All the way up to the neck of the gallbladder. And you can see that the wall is quite thick, but this is due to a medical cause. In this patient who has cirrhosis, we see a significant amount of ascites, so fluid around the dome of the liver, and then we see a markedly thick gallbladder wall. Again, a medical cause for gallbladder wall thickness. So what's wrong with this measurement? Well, you can see the calipers have been placed on what the sonographer thinks is the wall of the gallbladder. My argument would be that you need to measure a little bit further out, because this is indeed a thick gallbladder wall in a patient who ended up having cholecystitis. Let's move on to a discussion of cholecystitis. In this case, we're looking for things like wall edema, the loss of layers of the gallbladder wall. You can also see a transmural breakdown of the gallbladder wall with associated pericholecystic fluid. And finally, progression to gangrenous cholecystitis and perforation is certainly a possibility. Some other findings that you see on ultrasound with acute cholecystitis would be, number one, a sonographic Murphy sign. Number two, gallbladder distension, that same gallbladder wall thickening. Number four, intramural gallbladder wall edema. Number 5, the pericholecystic fluid that we discussed. And then number 6, intraluminal material like stones or sludge. What I'll also add to this list would be a dilated common bile duct, which may be the etiology of the cholecystitis due to a stone obstruction. Of note, wall abnormalities are much less common in chronic cholecystitis. So what do you end up seeing? Take a look at this longitudinal of the gallbladder and note that it appears quite large. We see a thickened wall adjacent to the liver with some wall edema, and there's also some shadowing stones towards the neck. So we have stones, gallbladder distension, wall thickness, and I'll tell you that this patient also had a sonographic Murphy sign. This patient had cholecystitis. This is another example of a patient with cholecystitis, as we see a number of shadowing stones, as well as a thickened wall that's adjacent to the liver parenchyma here. Next, on this scan we see a number of shadowing stones, as well as a markedly disrupted wall of the gallbladder. There was some concern that this patient actually had a perforation of the gallbladder wall. Certainly there was severe disease. This patient had acute cholecystitis. So let's talk a little bit more about pericholecystic fluid. Now this of course can occur in cases of medical patients having volume overload, things like end-stage renal disease, the CHF patients, the hepatitis patients, as we discussed before. But you do have to be concerned about cholecystitis when you see this. What it's referring to are the hypodense regions of edema that occur around the gallbladder, either free fluid in the gallbladder fossa, loculated fluid around the gallbladder. And as mentioned, it can be due to a variety of abdominal inflammatory or infectious conditions. So what do you end up seeing? You see a gallbladder lumen with some fluid just outside of it. This is indicated by the green arrow. So as we scan through the patient's gallbladder, this is a patient with cholecystitis. We see a nice wedge of fluid that's adjacent to the wall of the gallbladder. So this is pericholecystic fluid. This is another example in a short axis of the gallbladder. We see a nice wedge of anechoic fluid, which is pericholecystic fluid. Now, we mentioned another finding that occurs occasionally in acute cholecystitis is a stone obstruction in the common bile duct, which causes it to dilate. So revisiting this is the Mickey Mouse sign, with the CBD being the right ear of the Mickey Mouse as the Mickey Mouse is facing you. The CBD is usually less than 3 millimeters, but always less than 9 millimeters. There's typically 1 millimeter per decade of life, or age divided by 10. This is patients who are status post cholecystectomy. As noted, the CBD can be upwards of 13 millimeters in size. So we see here on the still image calipers which are measuring inside wall to inside wall of the CBD, with the portal vein and its color flow documented just below that. If we watch this in a video, we see that there's no color flow through the dilated common bile duct. Okay. Let's give you another example of this. This is another still image with a CBD layering just next to the patient's portal vein. If we then turn this into longitudinal, we see a markedly dilated common bile duct, which on this video does not show any color flow. This is a patient who had choledocholithiasis. Taking the right upper quadrant scan a step further involves a discussion of the intrahepatic bile ducts. Typically in a normal patient, you don't see anything at all. However, once there is increased pressure in the system, typically due to a stone, you can have dilation of the intrahepatic bile ducts. And the end result of this is intrahepatic cholestasis. The way this is described sonographically is the double barrel sign, parallel channels, shotgun, trolley tracks, or too many tubes. The idea is that you have a lot more tubular structures within the parenchyma of the liver than you have in a normal patient. What you end up seeing, as identified on the screen, are portal structures that are accompanied by dilated biliary structures. On this video, we can see the same structures. And the first thing you'll notice, even if you don't know much about intrahepatic cholestasis, is that there's just a lot of tubes within the parenchyma of the liver. If we put some color flow to this, we realize that some of these don't light up, meaning that there's no flow through them. So these are the biliary structures. Again, this is the too many tubes sign that's consistent with intrahepatic cholestasis. This is another example of the same finding in a patient who had choledocholithiasis, as well as intrahepatic cholestasis. Just an overview of the transverse of the liver here, we just see that there's a lot of tubes. And when you see too many tubes, you have to be worried about intrahepatic cholestasis. Next, every once in a while, you'll come to the unfortunate conclusion that the parenchyma of the liver just doesn't look right, that there's a lot of heterogeneity to the sonographic density. Some areas are more hypodense, some are more hyperechoic. And so when you have this kind of variety, it's consistent with liver metastases. In this video, you can see that same finding here with a lot of heterogeneity, which is secondary to liver metastases. So let's summarize your biliary ultrasound. You want to ask yourself a couple of questions at the end of the scan. Number one, do I think the patient has biliary disease? You'll answer this question by a few other considerations. One being, is there any evidence of gallstones? Does the patient have a sonographic Murphy sign? Are there either gallbladder wall or pericholecystic abnormalities? The next part of this is then to spread your scope and ask yourself whether the common bile duct is normal in size. Is the morphology of the gallbladder normal? Is it particularly distended? Is there gallbladder hydrops? And then finally, is there upper biliary tract and or liver disease? Is there evidence of intrahepatic cholestasis? Do you see any abnormalities that would be consistent with liver metastases? And a final comment on sonographic documentation. Again, for this study, you'll want to obtain a longitudinal of the gallbladder. You'll also obtain 3 transverse views of the gallbladder with wall measurements on the portion of the wall adjacent to the liver parenchyma, both in high, mid, and low. You'll want a transverse of the liver, looking for any obvious liver pathology. And then finally, you'll measure the CBD in transverse from inside wall to inside wall. And of course, identifying pathology in 2 orthogonal planes. My last plug is to do a slow methodical scan, including videos of all of these structures as discussed.